Hello, everyone. Welcome to MIT Hacking Racism in Healthcare, the first hackathon focusing on racial disparities in healthcare. My name is Emir Argechan, and I'm one of the organizers of MIT Hacking Racism and a PhD student at MIT. Angel?
Hello, everybody. We are so excited to have you join us today. We are blessed to have your presence, and we look forward to you all participating in the MIT Hacking Racism Challenge. Today is going to be a glorious day focused on the fundamentals of eradicating racism through technology solutions, community activism, as well as policy. We are excited to have gathered together the thought leaders and geniuses, techies, and cultural activists from around the country to come together in solving this problem. We know that over the course of this weekend, you all will create the change that we want to see and build the solutions that we know that are possible to be able to propel us into the future. We want you to dream as ridiculously as possible. Put your all into it and allow your imagination to take you anywhere. There is no idea that is too grandiose or too small in an effort to eradicate racism. Emery?
Next slide, please. Thanks a lot, Angel. I really liked the speech you gave. And this effort wouldn't be possible without our sponsors. The sponsors gave us all we needed and all you will need in the process of making your ideas a reality. I want to thank MIT once again, and I would like to thank the organizing team, especially the Freddie Wen, who cannot be with us together today. Next slide, please. So we have a really diverse pool of applicants. Over the course of a month, we received a lot of applications from all over the world, mainly from the US. The race distribution and ethnicity distribution of our applicants are pretty diverse, and we received an enormous amount of applications from HBCUs. Thanks to Angel and Yusuf's efforts, to be honest. They did a really great job in terms of advertising. And we received a lot of mentors from National Society of Black Engineers as well as participants. Next slide, please. So hacking racism in healthcare is a really broad topic, and we would like our participants to narrow down their view and focus on specific problems. That's why we divided our hackathon into 7 different tracks: public health, population health and wellness, individual health and wellness, intersectionality, data bias and clinical research and trials, education and financial health, and social justice and policy. So through this weekend, you're assigned one of these hackathon tracks, and you'll be talking and discussing with your fellow hackers, and then you will try to find solutions. And think big. As Angel said, think big. I think we should start to make a dent in these really, really tough and complex problems. And you cannot imagine how a single individual can make a difference. Angel, do you have a comment about that? I think you're muted.
Thank you, Emery. Absolutely. You can come up with anything your mind can allow you to possibly think of. If you, for instance, feel as though there is a problem with the wait time that people experience in comparison to others, and you want to come up with a way to eliminate biases in terms of the emergency room wait time, if you think that there is a better way to be able to teach health education to youth or to single mothers that are in an impoverished neighborhood, or maybe they are a single mother for the first time in their family or something. I'm just making up stuff right now. basically trying to articulate that you can think of whatever you want to, and as long as you can justify and support how this is going to reduce bias and help with the mission of eradicating racism, we want and yearn to hear your ideas. Also know, once again, you do not have to be a coder. So when I first started, I was not necessarily a coder. So we want you to think in terms of large impact, not only things that can impact your community locally directly, but things that can have an impact across the country and eventually the world. It can be a bicycle, it can be an app, it can be a policy that you come up with, that some type of amendment that you want to create. It can be a concert or a mural or anything that your mind can possibly think of, as long as you can tell us how this is going to change the world, eradicate racism, and make a large impact in one of these tracks.
Thanks, Angel. I think we should start thinking right now, because today we will focusing on what are the problems pertaining to these tracks, and like later today and later, like early tomorrow, you'll be forming teams around the ideas of others or yours. So start thinking, because tonight there will be problem pitches. You'll be listening to problems from other participants, and you will have the opportunity to pitch your own problem. So start thinking about the potential problems, and you will hear a lot of good stuff from our keynote speakers. Next slide. So our first track is track A. It's about public health. We all know that racism is widely acknowledged as a public health issue, and states and cities are trying to acknowledge it as well, because it presents a major barrier to eradicate racial inequalities in health outcomes. Black, Indigenous, people of color are more likely to suffer from chronic health conditions and infectious diseases compared to non-minorities. And COVID has shown us that this is the case. And also the case of maltreatment contribute to frayed trust between healthcare providers and various minority communities. So in this track, we will focus on how to get rid of these issues. For example, how can we create community support services? How can we reduce harm to citizens by police and the violence it caused on the mental health of Black people? And how can we develop interventions to dismantle structural racism? And how can we contribute to the national global conversation around this issue? Next slide, please.
So we are very excited to welcome Dr. Tiffany Wilson, OBGYN extraordinaire. And at this time, we are going to turn it over to her and hear words of wisdom on public health.
So good evening. Good evening, everyone, and welcome to MIT's Hacking Racism in Healthcare. I am very, very pleased to be with you this evening, very excited for the things that you all will create and how they will change the face of racism, not only in this country, but in the world. So we're going to start off by just having a little bit of a discussion about racism in the public health space. So racism, as defined by the American Public Health Association, is the system of structuring opportunity and assigning value based on social interpretation of how one looks, which is what we call race. The system that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and sets the strength of the whole society through the waste of human resources. As we know, racism is currently considered a public health crisis because it declares value based on looks, whereby creating a system of extremes where some obtain highest levels of care while others obtain the bare minimum or less. Though this construct has been present throughout all of history, it is well documented as acceptable during the Jim Crow era. During this time, there were large gaps in healthcare, with minorities having poor access to care and poor quality healthcare when it was offered. They were only given care after doctors had spent countless hours caring for those more important, and minorities were cared for only after hours and if the doctor had time. Currently, we see examples of this crisis spanning many areas of healthcare, including life expectancy. Consider that the average life expectancy of African Americans is 4 years lower than the rest of the US population. We see it in maternal morbidity and mortality. Black women are up to 4 times more likely to die of pregnancy-related complications than white women. We see it in police violence, where African American men are more than twice as likely to be killed by police as white men. And even in cancer care and outcomes. The incidence of breast cancer, interestingly, is higher in non-Black women, but the overall mortality in African American women is much worse. This and other countless examples are those that lead to significant variances in healthcare access and delivery across our nation. As such, structural and systemic racism directly undermine the views of the Healthy People 2020 initiative launched by the Department of Health and Human Services in 2010. Subsequent to this, it undermines its 4 main goals of attaining high equality, longer lives free of preventable disease, disability, injury, and premature death. It undermines our goals to achieve health equity, eliminate disparities, and improve the health of all groups. It undermines an attempt to create social and physical environments that promote good health for all. And finally, it undermines the promise to promote quality of life, healthy development, and healthy behaviors across all life stages. Racism, when considered as a social determinant of health, exacerbates and perpetuates the trends that the field of public health desires to reverse. And in order to combat this behavior, it must be addressed across the board, not only by those who work directly in the public health space. Given this, it is important to realize that while racism is overt at times, it can also be subconscious and unintentional, creating inadvertent inequity in healthcare. Those in the healthcare space must then work towards valuing all parties equally and remain focused on breaking down the systemic discrimination that ascribes to what we now know are avoidable inequalities and the elimination of healthcare disparities. To work towards the elimination of healthcare disparities, we must consider that this is a multifactorial task with interventions that span various facets of medicine and other aspects of life. For the purpose of our hackathon this weekend, I will discuss interventions important to the aspects of healthcare. We must change our approach from healthcare to one that is reactive to proactive. Although 75%, a whopping 75% of US healthcare dollars are spent on preventable conditions, only 3% of healthcare dollars are actually spent on prevention. With more emphasis on prevention, the impact of improving overall health and reducing inequities in healthcare could be enormous. Ways to emphasize preventive care include ensuring access to care, emphasizing primary care, and eliminating inequities in the receipt of higher quality care. By ensuring access to care, such as providing access to health screenings and early interventions and treatments, inequities in care can be reduced and/or eliminated. The Affordable Care Act, by increasing coverage for 20 million Americans, reduced the care gap between whites and non-whites and eliminated the disparity for Asian Americans and Hawaiians. Also, because medical care in the US is largely focused on the treatment of disease, a shift in focus to place more emphasis on primary care is needed. It is well documented that population health is better in places with a higher ratio of primary care physicians. With regard to eliminating inequities in care, a report from the National Academy of Medicine found that across virtually every type of therapeutic intervention in the US, Blacks and other minorities received procedures and poorer quality medical care than whites. They concluded that, interestingly, implicit bias on the healthcare providers was a very likely contributor to these observed patterns and associated with biased treatment recommendations in the care of Black patients. This highlights the importance of understanding the conditions under which bias is most likely to occur so that bias can be eliminated. When considering the elimination of bias, healthcare workers who take the time to understand patients' social risk factors and needs are more likely to consider all aspects of their care needs. For example, giving consideration not only to a person's obesity status, but also considering their socioeconomic status, access to healthier food choices, number of people in the home, allow a healthcare provider to take a bigger look at the bigger picture. Looking at the bigger picture now allows the healthcare professional to take a more culturally sensitive and culturally competent approach to their patients' care. Additionally, there must be more diversity in the healthcare workforce. When the population of the workforce is as diverse as the patients they serve, it creates the best outcomes for the healthcare system. Research also indicates that underrepresented minorities are more likely to work with underserved populations. It also suggests that racial concordance between patients and clinicians yields better patient-provider communication, better overall health outcomes, higher levels of patient satisfaction and compliance with provider recommendations and medication regimens. For the participants in the hackathon this weekend, I hope that the information presented herein gives you a starting point for the great things that I know you will produce for this weekend. I thank you for your time and attention and the opportunity to be a part of this excellent experience.
Thank you so much, Dr. Wilson. I actually learned a lot listening to that. That was very informative. I think you did a wonderful job breaking it down and giving many of the participants some tools to be able to work with in many different ways to be able to prevent bias in public health. So thank you very much for that. That was extremely informative.
Actually, like it's the upcoming track B about population health and wellness is quite related to Tiffany's talk, because as we know, like Black, Indigenous, and people of color experience a lot of barriers hindering them accessing quality healthcare. And as Tiffany said, they live in medically underserved communities and have limited access to continuous affordable healthcare and health insurance. So in track B, the participants will try to tackle this problem. How can we deliver better preventative care and primary care for people of color and Black and indigenous people? How can we identify access barriers based on geographical factors and support people with telehealth and transportation? How can we create access and how can we eradicate language barriers and other barriers such as healthcare literacy? So
absolutely.
Start thinking about these problems.
Yes, yes. So we have an amazing speaker up next to follow up with that, Emory, and that is Chinoni Egbulam. I said it so good the last time. Forgive me, Chinoni. And she is with the CDC and helps run the Global Health Fellowship Program there. This is also an amazing lady, and we look forward to her thoughts on population health.
Can everyone hear me okay?
Yes, we don't quite see you yet, but yes.
Yeah, for some reason, it's as I try to start the video, it says you can't start your video because the host has stopped. Oh. Okay, can you see me now?
Yes.
Okay, great. Greetings, everyone. Good evening. Thank you all so much for tuning in and for embarking on the start of what will for sure be a fruitful weekend of sharing ideas, creating, innovating, networking, and more. As a gender specialist focusing heavily on how gender interacts with other social identities, such as race, class, immigration status, and more to help shape biases, the mission of MIT Hacking Racism in Healthcare Hackathon is so important to me. The reality is that across outcomes in education, health, housing, and nearly every other aspect of daily life here in the United States, race is the single most predictive indicator of one's success. At the start of the COVID-19 pandemic, I had the privilege of working with the CDC's International Task Force team for the COVID-19 emergency response activities. In this capacity, I found myself coming across many data visualizations, news articles, and research papers highlighting the same patterns for Black, Indigenous, and people of color. I came across one analysis written by the Commonwealth Fund in April, which showed that confirmed COVID-19 cases and deaths were disproportionately higher in communities with larger Black populations. Contributing to these poorer outcomes is the far greater likelihood that Black and Latino Americans live in poverty and reside in neighborhoods with overcrowded households, air pollution, and inadequate access to healthcare. Beyond its toll on physical health, the pandemic ultimately pushed the US into an economic recession, which typically already impacts disadvantaged people more severely than the rest of society. You may ask, what is the importance of disaggregating data by race, ethnicity, class, education, etc.? Well, that's where the discussion of population health and wellness comes into play. Many people think that population health and public health are one and the same, when in fact it's not. While they're interrelated, there are a few key differences between the two. The CDC defines population health as an interdisciplinary, customizable approach that allows health departments to connect practice to policy for change to happen locally. This approach utilizes non-traditional partnerships among different sectors of the community: public health, industry, academia, hospitals, nursing homes, etc., local government entities, in order to achieve positive health outcomes. Population health brings significant health concerns into focus and it addresses ways that resources can be allocated to overcome the problems that drive poor health conditions in any given community. Hence, population health is concerned with both the definition of measurements of health outcomes and the patterns of determinants. In this capacity, we are focusing on the wellness of community by addressing their specific needs and working to combat and eliminate the structural barriers that prevent access to resources and limit one's ability to adopt a healthy lifestyle. Determinants include medical care, public health interventions, individual behaviors, along with other components that are more what we classify as social determinants of health: income, education, employment, culture, and in some cases physical, by urban design, clean air, water, physical environments. So public health, on the other hand, can be defined as what we as a society do collectively to assure that the conditions in which people can be healthy. Federal and state public health policies and programs play an important role in the health of the overall population of a nation. But if we go deeper and look at the social determinants of health, the research shows that race and ethnicity are risk markers for other underlying conditions that impact health. To paint a solid picture, I'll share a scenario that one of my colleagues presented to me in the past. This excerpt was pulled from a book called Towards a Healthy Future, Second Report on the Health of Canadians. Why is Jason in the hospital? Because he has a bad infection in his leg. But why does he have an infection? Because he has a cut on his leg and it got infected. But why does he have a cut on his leg? Because he was playing in the junkyard next to his apartment building, and there was some sharp, jagged steel there that he fell on. But why was he playing in the junkyard? Because his neighborhood is kind of run down. A lot of kids play there, and there's no one there to supervise them. But why does he live in that neighborhood? Because his parents can't afford a nicer place to live. But why can't his parents afford a nicer place to live? Because his dad is unemployed and his mom is sick. But why is his dad unemployed? Because he doesn't have much education and he can't find a job. But why? Structural racism is pervasive in government, hospitals, nonprofit, and private systems, and the policies, practices, and procedures that create and uphold these systems is why we're here today. It's why Jason found himself in the hospital. It's why, it's why his dad is unemployed, because there are so many structural barriers that impede our abilities to thrive. That's where we hackers come into play. We as healthcare professionals and change agents must collaborate with disadvantaged populations to improve health statuses of their communities by promoting health, preventing disease, and addressing the health inequities through innovation. So for those of you who are in the population health and wellness track, as you are brewing with innovation, thinking about the development of effective population-based prevention strategies, I encourage you to think about how you can advocate to decrease health disparities. Think about policy making and how you can ultimately impact policy making to address these health disparities and improve health outcomes of populations in needs. This also incorporates the need to implement cost-effective strategies to address health disparities. Think about leadership strategies. Who do you know? Who are you connected to? Think about your network and the networks that can ultimately work with you to impact safety, cost, and clinical outcomes by design. Think about how you can collaborate and partner with community partners to execute educational approaches to improve clinical decision-making and evidence-based practice as you work to develop various guidelines. So in order to break down these structural barriers, as we all join forces to create a space for collaboration, let's take advantage of our diverse backgrounds to dismantle racial injustice in healthcare delivery and to address the social determinants of health. As Angel said, there's no idea that's too big or too small. Think big and best of luck to you. Thank you.
Thanks a lot, Shinonia.
Yes, I think that was very eloquent, Shinoni. Thank you so much. You painted the perfect picture of a very you illustrated it very well and helped us be in someone's shoes that might experience certain circumstances that would lead to non-optimal health outcomes. So as our hackers and our participants are going through the population health track, try to put yourself into a housing authority or a situation that might not have all of the resources that you are normally used to. And also think about times that you might be in an affluent hospital, but because of the color of your skin, you are now assumed to be different and are treated different. So there are many different ways to place yourself inside of a situation and kind of go through an ethnography process. I haven't eaten today. An ethnography process so that you can really feel as best as you can, leveraging participatory design to be able to come up with your ideas and construct them.
Thanks, Angel. I think if we zoom in a little bit, I think population starts with individuals. And I think in track C, we will focus on individuals and how we can try our best to improve their health. So in the US, as we all know, the mortality rates for various chronic diseases such as diabetes, hypertension, hyperlipidemia, have much higher death rates, and the mortality rates are much higher. And also, despite decades of health equity research describing health inequity, race still correlates with women's health and child death rates, unfortunately. So, what can we do to dismantle racial inequality and inequity for chronic disease patients, such as diabetics and cardiovascular disease sufferers? And also, how can we reduce uh, child deaths, and how can we improve obstetric health and Black, Indigenous, and people of color?
Absolutely. That this subject in particular is very near and dear to my heart. My mother has diabetes. I did my college thesis on diabetes prevention, and I think it's one of the most chronic illnesses that we face in our community. So putting a lot of thought around that would definitely go well in this hackathon. And we're excited to have Dr. Arkita Deruin with us. My sister from another mister from Hampton University, and she is the associate medical director at 98.6, and she is going to give us some more insight into this track. Welcome, Arkita.
Thank you guys for having me. I'm thrilled to be here. And as a Black female physician that's board certified in family medicine and lifestyle medicine, I was trained to consider the whole person and how their environment can affect their health outcomes. It's exciting to come here today and brainstorm ways as how we can impact an individual's health and at an individual level. So I'm excited for us to use this summit to work to address these issues to change the world. I would like for us to start by looking at some things that influence individual health. As mentioned in the previous talk, and a lot of the discussions from the Listing Summit from a few weeks ago, we know that there are disparities in the healthcare system. We have to actively put our health first and address those factors that influence disparities. Genetic disparities and predispositions are real, but sometimes things are caused by lifestyle habits. I like to tell some of my patients that yes, diabetes may run in your family, but it may be also due to the fact that no one runs in your family. So we can address some things by working on modifications that can make a large impact on your life and somehow sometimes decrease the risk of you having something that may even be genetic. For instance, we'll look at a few things that are modifiable, like smoking. Smoking can not only impact the lungs, it impacts many diseases and body systems. And estimates show that smoking increases the risk of coronary heart disease by 2 to 4 times, stroke by 2 to 4 times, men develop lung cancer 25 times, and women over time develop lung cancer over 25.7 times. So quitting smoking can actually add years to your life, and that is not an exaggeration. There have been studies that have shown that someone who's quit smoking for more than 10 years actually can gain some capacity and function and have the decreased risk of developing cancers at the level of a non-smoker. Inactivity is also another thing that is very important that a lot of people don't think about. It's actually the 4th leading risk factor for global mortality. And most health benefits are achieved by exercise. So the recommendations are 150 minutes a week of moderate intensity exercise or 75 minutes of vigorous exercise during the week. And one of the greatest things that we can address is obesity. According to the CDC, non-Hispanic Blacks compose 49.6% with age-adjusted prevalence of obesity, followed by Hispanics at 44.8%, to non-Hispanic whites at 42.2%, and non-Hispanic Asians at 17.4%. As we all know, obesity can impact many things like diabetes, kidney issues, musculoskeletal issues that can affect things like arthritis and other stuff like hypertension. So I guess the biggest point of these discussions is that We have to do the work to give our bodies a fighting chance to decrease risk factors that increase our risk for developing. Also, in order to optimize individual health, you need a health partner. This can be a primary care physician. And as my last talk highlighted, there is distrust in the health system, which can be rightfully justified by African Americans. There have been experimentations on people, there were eugenics programs, there were segregation in different healthcare systems where certain people could only go to a community clinic on a specific day of the week, whereas other nationalities were allowed to go to the clinic wherever they wanted, which has led to a lot of distrust in the community and underutilization of primary care doctors. And to be frank, people kind of need a primary care home because prevention is power and preventative care is important. Navigating the healthcare system can be difficult and complicated. Primary care doctors can help navigate the healthcare system alongside you. They'll get to know you over time and note if any changes happen, be able to trend your lab work, and provide advice on measures that can prevent disease or catch it in its early stages, like weight loss or cancer screenings. They're able to review your medical records and recommendations from specialists and make sure that they're taking your whole body into consideration instead of a specific body part or system, which can help us avoid things like urgent care or emergency department services for things that are more primary care focused, rightfully so, because episodic care does not maintain wellness. There are some things that can be addressed to help with the inequities in the system, and that is kind of teaching people ways as to how to maximize office visits to get their point across. As we all know, when you're in the pediatrics realm versus being a young adult versus being an older adult, different visits have different goals and different things that need to be addressed. So we can start by teaching patients how to navigate the system with their doctors. For example, when you establish with a new doctor, have your medical records ready because at this point in time, there is no universal health medical records in America. The most common system that does have record sharing is the VA. They need to bring all of their medications and explain why they take them because different medications can be indicated for different disorders. And also write a list of your concerns and recognize that while they may not all be addressed at one visit, this can create a framework to collaborate with your doctor to create a more healthy state for yourself. So a lot of these things are advocating for your personal health by actively working on things that you can do better, but also working to trust your doctor to help you navigate the system. Now, I know that we are going to look into a lot of things this weekend discussing what is going to help us gain more equity and address certain things about social determinants of health. But I think I want to end by also saying that health equity is not something that we can achieve overnight. And as mentioned, it involves lots of factors about economics, education, neighborhood and environmental factors, social and community engagement, and of course, healthcare. We definitely need to come up with game plans to impact each of these realms with leaders in different roles in the communities, healthcare systems, and other key areas. But in this current state, we can't make much change without also thinking about how to address the political determinants of health. Some people believe that healthcare shouldn't be a political issue, but it is. When you vote, you're also voting for safer economies and neighborhoods and community empowerment and better educational systems, but you're also voting for cheaper medications, regulations on Medicare and Medicaid, which are socialized medicine, and you're also voting for initiatives to decrease food deserts that plague lower income communities and can impact things like obesity, heart disease, and cancers. So, in summary, the social determinants of health can be addressed to achieve health equity, but we need to advocate for policies to create and impact changes to restructure the system to help us work on both our individual health and our populations. I really appreciate being here tonight, and I'm looking forward to seeing what ideas you guys come up with this weekend.
Thank you, Arkita, for blessing us with that. That was amazing.
It was perfect.
Yes, I'm almost speechless. Thank you, doll. Okay, up next, we have Crystal Morgan, who is a PhD candidate with focus on provable fairness, differential privacy, and machine learning. But first, Emery is going to walk us through track D.
I think the speaker will explain a lot of things that I'm
Okay.
about to say, but it doesn't harm to go through them. I think many of us love AI and machine learning when it comes to healthcare, and they give sort of like good results, but we know that their predictive power is not perfect when it comes to Black, Indigenous, and people of color, because they're not represented well enough in the data sets used to train these platforms, especially like clinical trials and genetic studies. So if you're using these platforms and if you're relying on them, you're actually exacerbating inequities in healthcare, and you're amplifying racial bias in healthcare as well. And this is not only due to like sparse data sets, it's also because of the lack of trust. Not so many people, not so many Black, Indigenous, and people of color trust AI algorithms and healthcare professionals. And one of the examples is the Tuskegee study. So in this track, we will focus on those issues and how can we increase the trust to healthcare by using machine learning and AI algorithms. How can we build efficient machine learning and AI algorithms such that it doesn't have any racial bias? So in this track, we'll focus on those aspects.
Yes, well, as a data scientist, I'm quite excited to hear from Crystal, and she's an expert in this and has got many degrees in it. So Crystal, we're going to turn it over to you.
Perfect.
Hi, everyone. Oh, thank you so much. Thank you for having me tonight. My name is Crystal Moon, and I'm a second-year PhD student at the Plaid Lab at the University of Vermont. Next slide. I work day-to-day in my lab, which works on creating auditory mechanisms for fairness, verification, and privacy. We publish papers, build things, and socialize by drinking coffee and eating maple cookies. And tonight I'm here to talk about why fairness in data is super important. Next slide. Fairness is a problem in machine learning today. So on June 24th of this year, this article came out in the New York Times. This gentleman, Mr. Robert Julian Borchak Williams, received a phone call from the Detroit Police Department in January. At first, he thought it was a prank. He was handcuffed in front of his wife and two daughters in Farmington, Michigan. When his wife, Melissa, asked why he was being arrested, the police told her to Google it. So why was he being arrested? As it turns out, this case is important because it is claimed to be the first case of an American being wrongfully arrested based on a flawed match from a facial recognition algorithm. The larger problem was that we have faulty systems that unfortunately have a lack of diversity in the images used to develop the databases. So the data suffers from sampling bias. And one of the key issues that came up was how we would measure low quality search images, such as from grainy surveillance video. And what if these systems were use these images, particularly for undersampled individuals? Ideally, these systems should be tested rigorously for accuracy and bias. This is true, particularly if they're going to be used in arresting or sentencing humans. Next slide. In September of this year, the EFF wrote an article titled, "Technology Can't Predict Crime, It Can Only Weaponize Crime," and proximity to policing. It talks about how Santa Cruz was one of the first cities to experiment with predictive policing programs in 2011. And in June, they became the first city in the US to ban municipal use of predictive policing, which uses data-driven analytics to predict who will commit future crimes and where they will occur. The article argues that when these systems are used, what the systems do is that they're tailored to victimize communities that are already over-policed. and that is specifically communities of color, unhoused individuals, and immigrants, by using the cloak of scientific legitimacy and supposed unbiased nature of data. The author says that experts have pointed out that these algorithms often draw from flawed and non-transparent scores, such as gang databases, which have been subject to public scrutiny due to their lack of transparency. Next slide. These events have touched our own communities. In June of this year, a group of mathematicians, including Kathy O'Neill, who's the author of this book, Weapons of Math Destruction, declared a boycott against helping to create predictive policing tools. Over 1,500 other researchers joined the boycott, which states that given the structural racism and brutality in US policing, we do not believe that mathematicians should be collaborating with police departments in this matter. It is simply too easy to create a scientific veneer for racism. We demand that any algorithm with potential high impact face a public audit. For those who would like to do more, participating in this audit process is potentially a proactive way to use mathematical expertise to prevent abuses of power. It also concludes with a call to all departments with data science courses to implement learning outcomes that address the ethical, legal, and social implications of these tools. Next slide. In computer science, an article was published in Springer Nature called A Deep Neural Network Model to Predict Criminality Using Image Processing. The paper claimed to prove with some accuracy that one could predict criminality using facial recognition. By June 22nd of this year, over 2,435 professors, researchers, practitioners, and students spanning various fields signed a letter titled Abolish the Tech to Prison Pipeline. Some of the key points they advocated for were that the review committee publicly rescind the offer for publication of the specific study, along with an explanation of the criteria used to evaluate it, and that the publication issue a statement condemning the use of criminal justice statistics to predict criminality. They also advocated for the publication, acknowledging their role in incentivizing such harmful publications in the past, and that all publishers refrain from publishing such studies in the future. And this letter to Springer is definitely worth reading because it outlines why data validity cannot be solved with more cleaning or more data collection, and that having a face that looks a certain way doesn't cause an individual to commit a crime. The scary part about the study by Harrisburg University, which was published in Springer Nature, is that their intent was that their findings would be eventually used by law enforcement agencies and other intelligence agencies to prevent crime. Anyways, within 2 weeks, the publication did pull the article. Next slide. This summer, several companies pledged to shut down predictive policing platforms. Among them were Microsoft, IBM, and Amazon. I'm going to pause for a moment and say that it's a bit more complicated than this. One of the critiques of these company decisions in the wake of protesters nationwide calling for an end to police brutality and racial profiling is that these decisions do not heavily impact the bottom line of such companies. So Microsoft president has said that Microsoft has not sold its facial recognition technology to departments, and the company has backed legislation in California that would allow police use of the technology with some restrictions. And similarly, Amazon has promised to ban police use of its facial recognition technology for a year. And what happens after that year, only time will tell. However, it's a start that there is concern over the ethical use of technologies such as facial recognition and conversations about fairness and bias in our data and models. Next slide. So what is the root of these flawed algorithms? Is it just bad data? It's actually not that simple. As humans, we all have biases. One example of bias might be one in which, as the movie Picture a Scientist talks about, we struggle to picture a female scientist or a Black female scientist as being a real scientist. One of the scientists in the movie, an MIT biologist, says that people are more fallible than we thought. Men are preferred to women for the same accomplishments. Implicit bias is something we all carry in our head. I highly recommend watching the movie if you have the opportunity, but one of the studies they spoke about was the one in which they administered tests, such as the IAT, which is the implicit association test. It works in the assumption of two things that are paired together in our mind and how we will, over time, associate those two things as belonging together. The test is usually done with words and time. So examples are salt and pepper or ketchup and mustard. One scientist took the IAT as it related to men, women, and scientific careers. and found that it took significantly more time to make associations between women and technical or career-oriented words, even for herself. A similar study was done in which persons were told that two applicants were applying for lab manager jobs. Their only differences were their names. In this case, one was named Jennifer and the other was named John. They told the evaluators that both persons applied to be lab manager over the course of the last year. And what they found was that the female, in an assessment of the two applicants that were identical on paper, besides their gender, were consistently viewed as less competent, less likely to be hired, less likely to be mentored by a faculty member, and given a lower starting salary. Next slide. So here's a popular XKCD comic. I think it's a great example of showing something like group attribution bias, which is a form of bias. And it's defined as the human tendency to believe that an individual's characteristics always follow the beliefs of a group that they belong to, or a group's decisions reflect the feelings of all members. In this case, because the person on the left has ascribed an inability to do mathematics, as a group to girls, an individual girl is only represented by that group and not as an individual who might be able to do mathematics. So this can lead to false conclusions. And so to make an auditory system for fairness to help mitigate some of these biases, you might imagine that we need to quantify these metrics so that we can figure out if we're doing better or not when measuring bias. And as it turns out, these metrics often don't translate as cleanly in real life systems as they do theoretically. One of the books that talks about these failings is called Ghost Work by Gray and Surrey. The end goal is to make sure that these systems aren't being used to weaponize and be punitive towards certain groups that are historically underrepresented in our systems and data today. And that's where metrics tend to break, particularly in deep learning systems. Next slide. So meet Neil and Katie, you might recognize them. We want to make sure that just because Neil is Black or Katie is a woman, that they aren't receiving discriminatory predictions on obtaining loans. And we want to make sure that Neil has similar odds of receiving a loan as Katie or any other person in the population. In machine learning today, models still get these quite wrong. And because the field of machine learning today lacks representation in general of people who look like myself, we need people like you to work on these difficult problems with your perspectives. Next slide. So you are here tonight because you want to be part of making the world fairer and more equitable for all. Whether you just like making things or are curious about how to make the world better, we need people like you to help mitigate these problems. It's really important work for ensuring equity. Next slide. Thank you very much for your time.
Wow, thank you, Crystal. I just got my entire data science life. And I look forward to you joining the research study that we're doing on this as well and continued conversation. So thank you so much for that. That was beautiful and amazing. And we're going to have to set up a fireside chat as well. But okay, thank you. So the entire point of participating in a competition like this is for you guys to be able to come up with ideas and solutions that we will hopefully be able to help you commercialize after this by participating in our pre-accelerator, and then hopefully getting you guys into a mainstream, Y Combinator, 500 startups, MIT type accelerators where you can really get some funding into your company. So we're not really looking at this as just a once and done sort of weekend. We really want you to come up with something that is sustainable, that you can possibly be able to get funding for and be able to commercialize and build something amazing with it. So we have a young lady who has been able to do just that by the name of Candace Blacknell. And we're very excited to have her today because she embodies sort of the exact result that we're looking to come out of this. She is a health tech innovator where she has taken the time to sort of analyze the health industry and different components of public health and healthcare, and looking at them through the lens of what disparities may exist for the Black community, and then sort of matching that with machine learning and making it applicable to the entire global population. And I don't want to steal all of her thunder, but I do want to let you guys know and speak to Candace Blackmail.
Awesome. Thank you so much for having me. I'm excited to be here. I couldn't think of a better person to go behind than Crystals gave an awesome speech about machine learning. So I want to talk about machine learning and its uses through the lens of what we do at GABA. So I was 0.3 points away from failing my first year of medical school. And that was because, unlike my peers who had friends and families that had been doctors, I had no way of knowing that it would take anywhere from $2,000 to $4,000 in third-party study tools in order for me to be successful. So I want to show you that I absolutely wasn't alone. So this is a flat line specifically. So for medical people or fans of Grey's Anatomy, of course, this is never a good sign. And unfortunately, this represents the rate of diversification of medical education in this country over the last 10 years. And even worse, of the students that drop out of medical school, over half of those students are underrepresented minorities. So medical education has really attempted to solve this problem by establishing faculty-led initiatives that focus on individualized learning, pipeline engagement, and enhanced resource access. But unfortunately, they've been largely out of touch with what our minority and non-minority customers say is the worst part about being a medical student. And that's figuring out which study tools are going to help them be successful and accomplish their goals. Now, you probably experience the same lack of transparency when you go to the store and buy toothpaste or a toothbrush, except when you buy the wrong thing, it's a $5 mistake. When I buy the wrong thing, it's a multi-$1,000 mistake with terrible outcomes on my career, as is the case with Greg, Chris, and there I am right there in the middle. So Chris, my friend, recommended that I use a study tool called DIT. So I bought it for $800. And then I had to replace it with a $200 option that was much more effective. I then recommended that same study tool to Chris, because if it worked for me, it should work for her, right? Wrong. And of course, as you can see on the side, Greg had absolutely no chance in navigating this very complex system. And as our competitors have made more and more products and services that don't serve the student population well and are tone deaf and also stretch the limits of a student's budget, the GABA team has been working over 6 years to help medical trainees filter out all of this noise. Our web-based platform matches students with study tools and support services by combining the results of 6 cognitive assessments, user trends, and our database of 5 years of student performance outcomes. In just 2 months, GABA has established partnerships with Morehouse School of Medicine and Georgia Tech, acquired over 200 users on our platform, and 2 paid beta subscribers for $216 in revenue. We're just getting started. We regularly grow our users over 20% each month, and we saw 103% growth and 54% growth in June and July, respectively. And that was during peak exam season. So you might be asking yourself, medical students, that's not a lot of people. And you're right. We're planning to scale beyond medical students to all health professionals in the United States for a target market of 10 million medical trainees in the US. And unlike our competition, at an average of $45 a month, our B2C model allows us to gain $30 million of annual recurring revenue in the first 2 years before expanding to $10 billion in annual recurring revenue. We're just now getting started with making medical education smarter. But with GABA, the team, technology, and tenacity are already in place. And we will become the premier partner for institutions, not only hoping to retain their talented students, but grow their talented students. We're raising a $400,000 pre-seed to expand our platform and drive premium conversion. And we invite you to help us in leveraging machine learning to bring the transparency that Glassdoor brought to hiring to medical education. Thank you.
Yes, Candace, you better pitch, girl. Yes. So ladies and gentlemen, that is how you give a pitch, okay? So that is what we are looking for you guys to do. Thank you, Candace. We want you to come up with something highly innovative that dismisses bias and will ultimately help to eradicate racism and give a fair and equal shot in every single type of way possible. It needs to have a customer base. It needs to solve a big problem. It needs to have a good market size. And we want you to think of these things when you're thinking about it. Of course, we still also have the community activism projects as well as the policy. But if you're working on a technology solution, really try to put your thinking cap on and think large and big as a company that you can really build with this.
I think Candace raised the bar for track E because like it was a perfect pitch, and the track E is about like educational health, which is all about like all about the things that you mentioned, that like racial and ethnic minorities are not represented well in medical schools. How can we alleviate that? And then you gave a really good like pitch about it, so you raised the standards pretty high up.
Exactly, Emery, that was well said. And to elaborate on that subject more, we have the Dean of Honors College, my HBCU brother, Mark Bowles, from Morgan State University, and he is going to expound more on that subject. So Mark, we're going to turn it over to you.
Okay. Hello.
You're good
All
to
right.
go.
Okay, good to go. All right. Yeah, that was an excellent pitch. All the presenters before, they were great as well. Which kind of does raise the stakes a little bit for me as well. Now we talk about education and financial health. I think I'm gonna focus a little more on financial health. When we talk about financial health or well-being, it's super easy to kind of assume that financial health means being rich and having a lot of money. But in reality, financial wellness is all about financial security. Like physical health, financial health is fundamental to leading a happy and successful life, creating a sound financial present to help alleviate some of your current stresses throughout the course of your days. It lays the foundation for a stable and secure financial future. So what does that mean? Simply means between education, money or capital has a major effect on how we are treated. Combined with race, life becomes an uphill battle. A few things to note. More than 20 million people who have gained coverage under the Affordable Care Act, 2.8 million of them are African American, yet the population is still more likely to be uninsured than white Americans. That with respect to education, money, and race. The average American family spends about 11% on household income on health and premiums and out-of-pocket costs. However, that amount approaches 20% when we're dealing with African Americans and people of color. Public health insurance programs such as Medicaid are vital to ensure affordable health care and healthier outcomes, yet the 14 states have resisted Medicaid expansion, mostly in the South. Education, racism. Even with improved access to medical care under the Affordable Care Act, the disparities in health outcomes between African Americans and whites are stark. African American women are 3 times more likely to die of pregnancy-related causes than white women. African American infant mortality rate is twice the rate of white infants. Imagine if the numbers were reversed and white women and infants were dying at twice the rate. What would be done? Maybe that would be the beginning of hacking racism. The lack of financial health leads to certain social determinants of health, such as poverty, as spoken about before, income inequality, just like in the story of the previous presenter, food insecurity, a lack of safe, affordable housing that has implications on health risks and ability to attain health insurance coverage for African Americans. Another important social factor leading to poor health outcomes and economic disadvantage among African Americans is racism. Because not only is it a stressor leading to wear and tear on the body, but it also impacts who gets what in America, particularly healthcare. The American healthcare system compiled with inequalities that have disproportionate impact on people of color and marginalized groups. See, these inequalities contribute to gaps in health insurance coverage, uneven access to service, and poor health outcomes among certain populations. African Americans bear the brunt, as well as people of color and indigenous people, of these healthcare challenges. Why and how can we change this? A few general ideas. Raising public and provider awareness of racial and ethnic disparities in care, expanding health insurance coverage, improving the capacity of financial providers in underserved communities, increasing the knowledge base on cause and interventions reduces disparity. That's the educational part. If we can have society educated to know the struggles of some of the more disenfranchised people, it will lead to a little more equality. Money might not buy happiness, but it will open the doors that the system has made difficult for people of color. We cannot control the race in which we were born, but we can change the circumstances of how we relate, how we're treated, and how we live. Financial and educational health is probably the root of all of these things that will end racism. Thank you for the opportunity to speak, and I look forward to, great pitches and things to come. Thank you.
Thank you. I think it's very important. Thank you, Mark. I think it's very important about what you mentioned about the infant mortality and experiences that women face, and things going through the delivery room with 50% of the population being women. I don't think that actually gets talked about enough. So, and you're absolutely right. It totally boils down to financial health disparities and other things like that ultimately directly tie into healthcare and public health. And many people don't realize how deep that correlation is. So thank you for that and highlighting that. That was pretty awesome. So Emery, over to you to explain track F, social justice and policy. Everyone knows I can go on and on about it, and the brother that we have coming up next is definitely a special treat, but I'll let you highlight track F first.
Thanks, Angel. And one of the things that I realized that these tracks overlap too much, and I think these problems are pretty intertwined, and I think people should think collaboratively and think outside the box, and I think there's a great potential here. So track F is about social justice and policy. As we all know, like racism can be overt, but it can be hidden as well. And in healthcare, as we all heard, that can be subtle and also overt discriminatory procedures, practices, and policies, and they all contribute to racial disparities. So in this track, we will try to understand and dismantle racist and discriminatory policies, and how can we build advocacy efforts for healthcare? How can we identify and provide them resources for all key stakeholders? So I'm looking forward to this track because this is my track.
Sounds great. And this brother that's coming up is Chris Martin Stansell. He is one of my close friends since freshman year of college. I actually called him Sensei, and he is actually the person that enlightened me to the many disparities that the Black community was facing. I was just a naive young girl from Capitol Hill, And he broke a lot of things down to me and continues to teach me to this day.
94.
So I'm looking forward to learning in this discussion. And over to you, Brother Chris.
Hello?
Yes,
Peace.
we can hear you. We can't see you just yet.
Yeah, I'm trying to share the screen. Good evening. Not letting me share the screen. It's not letting me show my video. Oh, here it goes. All right. Evening. First I want to give praise to the great God. He's known by many different names. In Hebrew, he's Jehovah. In Egypt, he's Thot. But some call him God. I refer to him as Allah. But he's the causeless cause, the rootless root from which all things have grown. I give honors to the holy and divine prophet, Prophet Noble Drew Ali. I give honors to all true and divine prophets, Jesus, Muhammad, Buddha, and Confucius, etc. I give honors to all the panelists. I give honors to Angel. Yeah, we go way back. That's right. Hamptonian. We're striving to focus on a lot of great things, and I'm looking forward to it. I give honors to all the panelists and everyone who spoke before me and anyone who will speak after me. And it's a blessing to be amongst great minds and elite people who have a thought pattern that is focused on progression in our society and things that we're dealing with a lot of social disparities. And it's interesting as I was listening to the panelists, I know that everyone sounds motivated and eager to come up with brilliant ideas to address this problem of racism in our society. I'm going to briefly just go through the questions and a little bit about myself and how it's connected to this social justice component with this program at MIT. I give honors to MIT too for stepping out and having courage to address racism, and with this panel facilitating a discussion around these different areas. Well, first, I'm the CEO and co-founder of Life Matters LLC, along with my wife, who is a DNP candidate at the University of Rochester. She's a CNL nurse. I call her super nurse. She's a certified nurse leader, RN, BSN. And Life Matters is a company that focuses on holistic health and wellness. We're consultants. We host a number of trainings, national, state, and local, dealing with different non-for-profit schools, different agencies facilitating facilitator-driven dialogue trainings, race nonconformity trainings, and anti-race trainings. We also do trainings that are connected to critical race theory, and we focus on the global Moorish Holocaust, which a lot of my work was focused on in my undergraduate and master's studies. And it's we're still in the process of developing different partnerships. We've run Yoga in the Hood program, focusing on health and wellness in urban communities in Rochester, New York, Brooklyn, New York, and also in Tampa Bay, Florida. I'm currently working with secondary schools, colleges, and universities on one particular University of Rochester. A little bit about myself. I'm a Sheikh and a Divine Minister of the Moorish Science Temple of America, which is the first Islamic organization in America, and serve as an acting assistant Grand Sheikh of Temple number 34, study group in Syracuse, New York. The Moorish Science Temple of America is a program dedicated to uplifting fallen humanity and teaching the things necessary to make its members better citizens. And we teach our people their nationality and divine creed, our people who are known as Negroes, colored folks, Black people, Ethiopians. Some call them Black indigenous people of color. We call them Moorish Americans, and that is my nationality. As you notice, I have a headdress, which is my religious and national headdress is a fez. A little bit more about myself. I'm a special educator in Rochester City School District. And a lot of what I do is circled around education, social justice, community activism. I serve on the Race and Structural Equity Committee with Rochester, New York, and Monroe County currently, in a working group focused on business and community development. I'm a historian. I focus on the survey of the global Moorish Holocaust. If I could share the screen real briefly. Well, it's not room for that. It's not popping up. All right. Well, we'll move through. I looked at some of the questions that were under the social justice and thinking about how I work and the connection to it. My idea and focus mainly the objective is focused on if we're serious about eradicating racism, we need to seriously examine race as a social structure and the eradication of the color code classification system. Now, it's not to be confused with color blindness. If we look at the origins of racism and focus on eradicating, one of the ideas that I'm focused on is getting back to American core values. Studies from the Honorable Derek Bell, who's the godfather of critical race theory, talked about race and dealing with race is a permanent issue because it's a social issue. When you're talking about the way people think and racism, some people take racism as a system and racist acts and lump them all together and then say, all right, this is what we're dealing with. Well, if you look at the critical race theory, it's really a framework to study racism and to gather data and to try to figure out ways to solve racism. But Derek Bell said you can't solve it because it's a permanent problem. That gives people a lot of disparity when they go into researching how to solve the race problem. And our position is to eradicate the color code classification system, meaning if you believe that race has a system and it has a hierarchy, we know that white is known as the top of the hierarchy and black is at the bottom, or black and brown would be at the bottom. And this way of thinking is actually new. So if you look at racism as a public health crisis, well, at once it was actually embraced. If you go and research the white nationalist movement, 1854, Horace Greeley, who was the founder editor of New York Tribune, he was basically the Malcolm X of the white nationalist movements. If you're familiar with the Red Wigs parties and the foundation of the Republican Party, a lot of it stems from European coming together to be white and classified as white. Where if you look at the situation of people of African descent in America who were stripped of their nationality at the Continental Congress of 1774. And it's no strange happenings. This actually happened a few days ago where the Moors commemorate the event of Moorish descents, Moorish ancestors having their nationality stripped from them at Carpenter's Hall in Philadelphia. And this is the formation, a part of the Continental Congress and the formation of America. So you look at American values, three things come to mind. The first three words in the United States Constitution, which is we the people. People are not crayons. People have been started to embrace these terms at a later date. And when it comes to people of African descent, the term changes up every 10 years. Negro, Black, colored, Afro-American, Black nationalist movements really was 1960s. But, our the label and we know it as the identity crisis is something that stems from Reconstruction era, but also to, if you're familiar with Goldenow and Blumenbach and their structure of the race paradigm during the 17th century. So looking at policies surrounded by race, one of the main things that we focus on is the eradication of Directive 15 as a federal standard through the Office of Management and Budget. So Office of Management and Budget are responsible for the census. And everywhere you go, locally, state, nationally, you receive forms and they have race on them. For instance, how is this connected to health? Well, when you go to the doctor's office, you have a chart. And on your chart, they have a race classification. Now, me being a Moorish American, every time I go to the doctor, I have to check my chart because someone feels they want to switch it back for data purposes. Well, I don't subscribe to being Black. So then they will say, well, they have you down as Black. Well, you have to change it because that is not who I am. I'm non-race conforming. I'm not colorblind. I understand the psychology involved with people identifying under the race classification system, but I'm being proactive by leaving it alone. If we know that it's permanent, why perpetuate race and keep on embracing the labels that delude to slavery, and also putting people in classifications as white when they have nationalities? Everyone has, and this is an old world concept in America. If we think about the founding fathers of America, when they came together, they were not white men. They had nationalities, and they weren't calling themselves white at that time. This is something that has evolved into American core values. Just recently, September 4th, it was a executive directive issued by President Trump, Executive Directive Order 13950. And it states it was issued to combat offensive and anti-American race and sex stereotyping and scapegoating. The Office of Management and Budget memo stated that such training undercuts the core values of America and drives further division in the country. The Office of Management and Budget instructed all agencies to identify contracts or spending on any training on critical race theory. So critical race theory, which was a framework that was developed by Derek Bell, white privilege, or any other training or propaganda efforts that teaches or suggests either that the US is inherently evil or racist country, or that any race or ethnicity is inherently evil or racist. So if you want to jot it down as a point of reference, Executive Order 13950. Research behind that, if you look into the American Anthropological Association, their view is they expressed in an article that ethnicity and nationality are more salient than race. So the position of the Moorish Science Temple of America, and also as Life Matters LLC, is that we promote ethnicity and race ethnicity and nationality as opposed to race in efforts to eradicate racism. Looking at the question, how can we better connect healthcare administrators and policymakers? Well, let's look at the policy. The policy that impacts local practices when it deals with race, the first race thing they deal with race when they're dealing with providers and patients is that they have to identify. So when you think about how this connection between patients and providers, we know it's a distrust relationship, but a person is asked to identify. We're thinking forward and moving forward and thinking, how does this connect to tech? Well, if an algorithm was created where a person wouldn't be given racial labels to check off, instead to provide their own, then data could be organized under people's own choice of person, the way they identify. Because if identity is on the table, identity shouldn't be presented to someone as a default. So because some people don't have anything to check. So they say, well, I see a list of these races and I don't see my race. And then now it's not inclusive. These practices really bother people. Like if you think about people of color, when you use the term people of color, you're saying that there is a default human. If there's a default human, then who's of color and who's not of color? Because last time I checked, colors were adjectives and people are people, places, or things. So we're addressing the psychology of American thought. And thinking about American core values, our nation embraced nationality at first. Out of many is one. If you look on the dollar, numerous pluma. If you look on the dollar, you talk about out of many is one. The old world thinking. When you come to America, everyone has two flags. You have the flag of your descent nature, and you have the flag of your birth. If flag of your descent nature is multiple flags, this means that you have multiple nationalities that represent your identity and your forefathers.
Yeah. So Chris, yeah, you know, I wish we were able to get into that part a little bit more and talk about the 1660s and basically to summarize what Chris is getting at here. I know it could be a lot that he's throwing at you. Basically, if everybody could just look up in 1660, the term race did not used to really exist in America. That's basically what Chris is explaining here. There were Moors as well as Black people here, and they wanted to sort of strip us of our land So they came up with this term race and started putting various different labels on us. But when the forefathers and different people first arrived to this country and throughout the world, that was not really a term. It was established in the 1660s, and many people don't realize that. So, so thank you, Chris. We appreciate you for that word.
Thanks,
And yes, thank you. And we are now welcoming Dr. Esteban Gershonik. And before we do that, we're going to have Emery present us with track G on intersectionality.
Thanks, Angel, and thanks, Chris. I think that what Chris said overlaps pretty well with intersectionality, because he said, like, we're not only like white or black, or we don't need to identify ourselves with a single descriptive adjective. We're all complex individuals, and we have overlapping identities, experiences, and these are the things that define ourselves. And if you think about like Black, Indigenous, and people of color, gender identity, sexual orientation, disability, and age can actually play an amplified role in accessing healthcare, and they can be a really huge determinants of health. So in this track, we will tackle those problems. How can we address these complex health needs of individuals affected by, for example, substance use disorder? Or how can we improve the health of LGBTQIA members and transgenders that are also Black, Indigenous, and people of color? So with that, I will pass on to Esteban Gershonik, and welcome again.
Can y'all hear me okay?
Yes, I can.
Okay. Thanks so much. I appreciate it. Great job by Chris and Angel there, sort of hitting at the core of critical race theory and the dynamics of it. And this is a good transition to intersectionality and what it means. And so, and one of the complications of how historically it sort of has captured aspects of how complicated some of the data is. So for those who are going to hit at this, sort of how you can sort of take a closer look and see all the dynamics that correlate with everything that we've been doing today. So with that, I'm going to, if I can sort of get some of the components of, let me see if I can start my slides here. All right. My apologies. All right. Stay there. So first and foremost, my name is Esteban Gershonik. I am a human being who was born in Shreveport, Louisiana, to two Argentine Jewish immigrants with Ukrainian roots, one of which was disabled, educated, and I grew up in New Orleans and became a physician with a master's in public health systems, and clinical informatics. Ended up minoring in African studies, and my best friend's Pakistani Muslim. So there's a lot of dynamics and data points there, which often you don't capture when you do and look at your basic information on healthcare as a whole. So we're all complex individuals. We have overlapping identities and experiences. And I think often in the data, or what people try to do, race as a whole is trying to simplify some of these things. So our key here is how can we hack racism in order to sort of better understand some of these issues with the aspect of intersectionality. Now, as we mentioned, the mission with this weekend is to create a space for collaboration around all these aspects of diverse backgrounds to dismantle race in healthcare delivery and address social determinants of health, intersectionality, and various other aspects. Intersectionality is familiar, it's and so forth and so on, combined through different modes of discrimination and privilege. It identifies advantages and disadvantages and overlapping aspects that are both empowering and oppressing. Furthermore, it's the interconnected nature of all these social categorizations that people try to put us in these boxes, right? That are a social construct. And our job is to try to figure out and break these things down so that we can have a better understanding of them all. It's also the idea of the oppressions, whether based on race, gender, class, sexuality, disability, nationality, all these categories that are social constructs. We have to break through it and better understand it. A couple of figures that I think help simplify this, instead of putting someone in one bucket, which often many studies do or evaluations in healthcare or public health do. The idea of population health also does that, with the conflict of what population health is compared to personalized and precision healthcare. Is the idea defined as plus our own experience. Now, in 2002, the Institute of Medicine had this unequal treatment report that sort of talked about disparities in healthcare delivery and disparities between various races, genders, sexualities, so forth. But it doesn't combine all those intersexualities to interconnectedness to better understand everyone sort of with all those bases. Public health, healthcare delivery is often broken down in silos, and people are trying to simplify issues that are more complex to individuals. So despite all these advances that we've had throughout the years in public health, racial ethnic minorities suffering increased morbidity and mortality around chronic diseases, we see that constantly these things are bucketed simply in one bucket that we have. Because often those people that are the minorities, if you want to put it that way, don't have the funding or the understanding of how to properly care for them because of the structure in which all of it was created. Now, currently, what most of the data has is basically the gender, the race, which again is usually limited to just 5 racial groups nationally, ethnicity, zip code, socioeconomic status, education. And often this data, you have to look at it, is often survey data or limited populations. I want people to think critically about that. Secondly, we talked about the social determinants of health earlier and how all these things are constructed well as to why there's healthcare disparities. This is the aspect of the economic component, the neighborhood that one lives in. Often folks who live in areas that have increased lead levels have
Esteban, could you turn off your camera, please? I think you're being cut off. Esteban, can you hear us?
I can hear you. Can you hear me?
Now I can. I think because of bandwidth limitations, while you were sharing screen, we couldn't hear you properly. So maybe you can turn off your camera and then we can hear you better.
Are we good now? Yeah,
you can go ahead. I can hear you, I guess.
Okay. So as we know, with some of the racial and ethnic disparity work around pregnancy, Black women have a higher prevalence than white women and American Indian, Alaska Native women. But what doesn't get it broken down to until you look at the most recent study that came out the last 2 years are the aspects of how this affects people by age, as you have here. And you can sort of, I'm just going to go through this quickly, and the idea of education. And so when you look at this, you can look at Black women who have college degrees or higher have a much greater, 8 to 40 of disparities around some of that morbidity and mortality when it comes along with education as well. And that's why we see folks like, often people think, oh, it's the socioeconomic issues, but that's why you have aspects of Serena Williams when she's 36, Beyonce, and most recently, you have our Thai Norwegian with a Black man having difficulties no matter the money that they have, how it affects them. The other component to look at all this is the idea that there's a lack of diverse positions in the workforce. And a recent article this last year talked about how when Black newborns are cared for by Black physicians, the mortality penalty they suffer as compared with white infants is half. So the fact that if you have a provider from your background who takes care of you, that is a better outcome. Furthermore, with sexual orientation, rates of tobacco use, suicide attempts, HIV, overall, everything is increased. So we talked about structural racism. That's been talked about or structural deep wounds that have been there for a while. And that's the hidden toll with all this. This is why the prevalence in Black populations, Latino communities, Native American, where the data is even less. What that the accuracy, the comprehensiveness, the timing of at the core of the issues around healthcare disparities. So with that, there's various neighborhoods looking at all these components that put things together to make a healthy community and intersectionality of various individual populations. And as the American Academy of Family Practitioners said, the key is to sort of get greater information so that you can target some of these complexities of individuals and groups of people, and you can understand it holistically instead of trying to put people in single buckets. With that, I'll give it back to you, and just wanted to at least provide a broad overview as to what intersectionality is and how to approach it.
Thanks a lot, Esteban. I think it was a really good comment on intersectionality. I think all of us are complex individuals, and sometimes we digitize things into like Black, white, or American, non-American. I think we're more than that, and I think we should consider that in healthcare as well.
Yeah, and I think Chris mentioned that, just before me, about how it's a construct that people are trying to simplify, and our job is to advocate that it's more complex than that, and we have to get things right and comprehensively so that people aren't grouping us, so that we can better understand what the outcomes are for all of us. Because at the end of the day, we're all humans who need sort of interactions and the complexity of it to really target how we can improve our healthcare disparities in our population.
Perfect. Thanks a lot, Esteban, once again. And I think we're moving on to, we covered all the tracks and we had really amazing people talking about the tracks. And right now, many people might think that, oh, this is a 3-day hackathon and this is really short amount of time. We cannot solve these complex problems in a 3-day period. And now we would like to show you that that's not the case. Never, ever believe in that. So today, Guillermo and Yusuf will talk about their ventures called vPool. And it's a success story from one of our previous hackathons called MIT COVID-19 Challenge Beat the Pandemic. So without further ado, maybe I should give the floor to Yusuf and Guillermo.
Hello. How you guys doing?
Hey, Yusuf, how are you, man?
Doing all right. Well, I've been enjoying these presentation. We want to introduce ourselves. My name is Yusuf Enriquez. I'm Chief Strategy Officer of vPool. I'm gonna say a little bit about Guillermo. Last 2 weeks ago, I had the pleasure of Zen introducing me to the group, and so I'm paying it forward. That's how Zen, myself, and Guillermo has been looking at this transformation. Met Guillermo end of May during BTP, Beat the Pandemic 2. Loved the idea of what him and his team was doing. Decided to lend my background of being at the FDA and thinking through some of the regulatory pathways and startup ideas that he may encounter once they had made the decision to form a company out of the BTP challenge that they won twice, early in May and then late May. Been a tremendous experience working with those guys. Smart, been thinking through the problem very methodically, and I've just been privileged to watch them grow over the last few months. It seems like a year, and I'll let Guillermo touch a little bit on that. But this is just a testament of, what this challenge could do, and hopefully you guys see the value of what these guys have created that started out of a weekend challenge, as Emery mentioned, of hacking COVID. So I'll turn it over to Guillermo and introduce himself and talk a little bit about WePool and the journey.
Hey, thanks, Yusuf, and I really appreciate your help so far. And thanks again, guys, for having me. As Yusuf was saying, my name's Guillermo. I'm from El Salvador in Central America. I'm an incoming MBA candidate at MIT. I was supposed to start in the fall, but due to COVID and several other reasons, WePool included, I chose to defer until next year. And so as co-founder and CEO of WePool, what we've been focused on is maximizing disease testing efficiency. As Yusuf was saying, we came together during the MIT COVID-19 hackathon. That one took place in April, and then there was a second round in end of May, June, and we've been working on this initiative ever since. And so, like many of you, really what we were focused on was solving a clear problem. In our instance, it was COVID-19. It's no secret we face a global problem with COVID-19. With 7 million infections in the U.S. and 200,000 deaths, the U.S. accounts for 20% of all deaths. And so, when it comes to managing pandemics, testing is key to identify people with the virus and slow its spread, right? So experts have been saying for the longest time, and I keep repeating this, that we should be doing lots of tests. Many say 30 million a week, many say 30 million a day. And although we've been ramping up testing, the US is still quite short of that. And the way most labs work is simple in PCR testing, and that each sample is tested individually, and this is amplified across the population. So let me take you through an example. Let's go through it together, right? So here we have 9 samples and we have 9 tests. And so addressing demand is difficult because testing is time consuming, it requires limited materials, and it's expensive. And so to solve this, what many labs are starting to adopt now, finally, in the US after Dr. Fauci started talking about pooling, is pool testing. And so in pool testing, what you do is you take individual samples and then you mix them into a single pool, right? Or a single group. And so if this group tests negative, then that confirms that everyone in the pool was negative, or everyone who was sampled was negative. And so then if the pool comes back positive, then you individually retest each of the samples to figure out who was positive and who was negative. And so here, even with a positive, here in this example, if you do pool testing, you still manage that population with fewer tests, right? And so this technique has enormous potential if you consistently manage to arrange pools of only negative samples, but that's not always the case, right? Pool testing has a flaw, and that's a disease positivity rate. Watch what happens if we just add one more positive into this example. You see, pooling becomes ineffective because you end up having to retest so many pools. And one example of this happening is Florida, when a lab was given an emergency use authorization to do pooling, Quest Diagnostics, but then they backed out to do individual testing because COVID was too prevalent, right? And so, as is the case with the COVID-19 pandemic, pooling becomes ineffective. And so how do we pool better? This is where we really started to think about this in the hackathon. And so what we came up with is that if we use AI, we can artificially reduce that prevalence by intelligently arranging pools of only negative samples, right? So hospitals and labs today collect socio-demographic and healthcare data that we can use to calculate each sample or each subject's pre-test probability of testing negative. So things like, you have it here on the screen: age, symptoms, reason for testing, general socio-demographics. I mean, for example, I think it was Freddie saying the other day that Black Americans are 3 times more likely to contract COVID. And so if we can pull all of this information together, right? And to come up with a pretest probability, who's positive and who's negative. Then with that, we can arrange the samples so that we can pool the ones that we think are negative, and we weed out obvious or likely positives from prospective pools, right? And so the result is that even though we added one more positive in that example, even if the prevalence rate is relatively high, we can still enable drastic savings and increases in capacity, right? And so look, this is what our prototype looks like. We're getting ready to pilot this in 3 sites. We tested this on precision FDA data sets, and what we found was that with this approach, we can save up to 70% of tests used and increase testing capacity by 300%. And so, you know, and we can use this for different test types. It doesn't just have to be PCR. And going forward in the future, we can adapt this model for other infectious diseases too. We have interested parties that want to use it for influenza, others for HPV. And also we want to be able to incorporate this technology into the robotic systems so that we can automate and optimize the entire pool testing process in the lab. This is the Opentron ZOT2 that's doing pool testing today. Another thing that we've been talking about with the Cambridge Innovation Center is that maybe we do pooling upstream, not at the lab, but before, at the collection site, in schools, whatever, based on household. We can train the algorithm to try and predict who we should pool and who we shouldn't pool based on that data, so that we can pool the specimens before we send them to the lab. And so this is what we've been working on, you know, since April, that, like Yusuf was saying, and you know, if anything came out of that hackathon that I'm really happy about, is that we've been able to build a fantastic team, right? And initially, just in the first hackathon, it just started with a few of us, and then in that second hackathon, fortunately, we won that first hackathon. We were one of the winners, rather. And then in that second hackathon, we happened to win again. And so the team keeps growing. We've built a multidisciplinary team, much smarter and more experienced than I am in the subject. And so the vision that we have is we want to enable efficient testing for the millions who need it daily. And so we believe that WePool AI will become like a standardized tool so that we're ready not just for this pandemic, but for the next one, or for other infectious diseases and things like this. And so, you know, just going very quickly to what we've been able to accomplish in just a few months, you know, as I was saying, we started with the MIT hackathons, and then University of California reached out to us, you know, what if we could do a prospective study? They'll give us access to some records so that we can train and validate the model and then use it through a prospective study and figure out the cost effectiveness of the tool. We incorporated and filed a provisional patent, which that was not easy. And so I was very lucky to have people like Yusuf, who have extensive startup experience, and as well as others in my team that guide me through this process. You know, in addition to that, we've recently joined the Creative Destruction Lab cohort for 2020, 2021, which is really important to me because basically their mission is to turn science projects into massively scalable products that benefit mankind. And you know, if that's something that we can do, that'd be fantastic. We've also been invited to present at the health event, which took place this week, and that was a fantastic exposure, networking, and learning opportunity. We're also semi-finalists in the $5 million X Prize rapid testing competition. And really, what we want to do is we want to be able to be a mitigating factor in one of the problems that is most affecting us today. And so hopefully that gives you guys a small glimpse of what can come out of a hackathon. You know, I certainly hope that we can be successful. If anything, you know, just identify methodologies and study procedures so that we can be ready for the next pandemic. But certainly, you know, within the next couple of months and definitely leading up to my MBA candidacy at MIT, this is something that I really want to follow through with in conjunction with my team so that we can be a mitigating factor in this pandemic. And so thank you guys for having me. You know, if you have any questions, if you have any comments or any suggestions, you can feel free to reach out to us, and I'll be happy to hear your thoughts. And Yusuf, if there's anything that you feel I haven't covered, you've been there along with us for the ride. And so Just let
No, appreciate it. I think we're running out of time. Just to get back on track. I mean, this just gives you a testament. I mean, 5 months, we've been able to accomplish all of that. So, as the panelists have said, think big, think outside the box, because the support that we're getting from MIT and others will be able to drive some of those ideas that come out of these hackathons, and will really be able to make a difference. And so, appreciate you guys having us.
Yep. Thank you. Thank you, guys.
Thanks a lot,
Thank
Guillermo
you.
and Yusuf. Angel, go ahead.
Yeah, I must say, Guillermo, you might not know how much I've been watching you, but since the beginning of you winning the competition, actually since the beginning of you even entering the competition, I've been following you. So it's been a joy to watch your journey and see all of the amazing things that you've been able to do. And I can only wait to see where you're at a year from now. I can only imagine you're going to be hosting your own hackathon. So congratulations on everything that you've been able to achieve. Yes. So up next, we are in for a treat. This is a combination of a few different interesting features. This is a edutainment presentation we are about to give you with Micah Brown of Brain Wrapper. He is a neuroscientist that loves hackathons, and he actually came up with Brain Wrapper during a hackathon. And it is a combination between a ghostwriting machine and he can explain it better than I can. So let me not even try. But he's also going to do some live demonstration for us and entertain us a little bit. So Micah, are you there?
I'm here. Can you guys hear me?
I'm excited. I should also mention he is a Grammy-nominated rapper, so he often gets torn between his tech career and his rap career, so he decided to combine them. So, Micah, over to you.
Thank you, Angel. Given I think the technical nature of everybody's conversations today, and as a techie myself, I think I'll take the first part of my presentation to just talk about some of the cultural aspects of this hackathon. I think how significant it is for people of color, the collection of people of color that we have on the hackathon here, and potentially what can come out of it in an actionable way in this cultural moment in America. And then I'm going to talk about my venture fund and a project we have called Singularity, which applies to some of these things. And then I'll do a demo of Brain Wraps, which I think everybody's very excited about. So just to give you some quick background, I'm the GP of a fund called Sentiment Capital. We're an early stage $5 million fund focused on neuroscience companies. And I'm also the CEO of a company called Brain Wrap. Brain Wrap emerged out of a now legendary hackathon, the Reality Virtually Hackathon, where I led one of the first teams of color there to a win through the People's Choice Award with the Brain Wrap product. That precursor 2020, in terms of where we are from an election perspective, in terms of the conversation about race, in terms of the role race plays in healthcare, in terms of the role race plays in money, and how those two things intersect with one another, money and healthcare. And so, I think that this hackathon is very timely. I think that this hackathon is very needed. I think there's definitely almost two schools of thought about how you change things in America for people of color. Today I saw an interview from Diddy talking about putting together basically a super PAC. And that's one kind of route. And then, the other is to go and protest, right? So there's these two routes: policy, changing policy, enacting the change in policy, enacting the change in the monetary system, enacting changes in structural racism, right? And protesting. And there's nothing wrong with protesting. Protesting is I think it's a First Amendment right. It's as American as apple pie, right? But particularly for people of color who, Black people particularly, who've almost been there and done that so many times, we really need to start to review, the leverage that comes with the power that comes with running companies, funded companies, changing venture funds, changing policy. From a very macro perspective, that's been done before, but from a very macro perspective, scaling and using the power of the dollar, especially in the VC world, from exceptional ideas to be able to create that leverage and create that power. And so, you know, I think that this hackathon is very timely for that reason. So that's the first part of what I wanted to talk about. I wanted to kind of give kudos to Angel. She pulled this together incredibly, and it's so tightly run. It's amazing, which is spectacular. And I really want to congratulate her for that. And I want to congratulate everyone on the call. You know, when I won the hackathon that I did, and then, you know, it got to be known by Fast Company and all these different things that's happened since, you know, I was just doing a hackathon, right? But the presence of Black people in any technological environment, right? The presence of software engineers of color in any environment where artificial intelligence and scalable machine learning are used is so significant. So I really want to say to everyone on the call, everyone on the Zoom, and who's going to take part in the hackathon today, congratulations. You know, whether you win or not, whether you come top 10 or not, just being here, just showing up, the presence of people of color, this many people of color in a forum like this is incredible. So with all that said, I'm going to talk about Singularity, which is one of the projects we have at Sentiment Capital very quickly. And then I will talk about how it relates to BrainWrap. 1 second. All right, let's move this down here. Cool. So you know, BrainWrap sits within Sentiment Capital, and Sentiment Capital really came from a hackathon, which is some footage here in 2017, where we were able to, it was the first hackathon before I kind of won the second one that I went to at MIT with another team of color. And we were able to create basically a very early stage way to correlate detection of Alzheimer's. Now, naturally, Alzheimer's is a neurodegenerative disease. So, you know, the biological, bioentomological, and other things that kind of link into those things are one thing, right? So, you know, really what Singularity is focused on is the diagnosis process, automating all of the insurance processes associated with diagnosis, reducing cost, right? You know, as we see over long periods of time, you know, diagnosis and the cost that comes with healthcare are at the heart of what affect people of color in this country. So that's the idea behind Singularity. And, you know, the way we work is in reducing insurance costs, we're actually able to increase insurance coverage. And, you know, we are putting together basically insurance pools to be able to cover people of color costs in a cost-effective way that works with the exchanges. So that's Singularity. And so we've only got 5 minutes here. So I'll actually kind of like jump into BrainWrap a little bit. So, you know, the idea behind BrainWrap and how it links to Singularity is pretty interesting, right? Just you guys can see that. Should be able to see my screen there. Yeah, perfect. And I'll just do that. And 1 second. Boom, boom, boom. Yeah, we go. Okay, yeah. So the way that these two things link together is, you know, as kind of any data scientist on the call will know, your F-score, the coarseness of the feature space around any type of data model that you build are dependent on the quality of the data, right? And so if you're trying to diagnose neurodegenerative diseases, understand the relationship between sound and thought, which relates to those things, then there's two ways you can go about that. You can stick a headset on everyone in the world, and very few people want to wear a headset, right? Or you can go the other way. You can compress the neuroscience into a web platform and then have people simply speak and, you know, confirm focus group information that drives feature space understanding that helps this neuroscience problem of understanding the brain in order to cure it, right? And whether it's neurodegenerative diseases, neuroentomological diseases, whatever it is. So that's what this is. This is BrainWrap. And if I stop speaking for a sec.
Hey, Mike, I think you might want to refresh. Folks are not able to see. All they see is a business model.
Oh, okay, cool. 1 sec. Let's do that. And you share. There we go. Boom.
You have a pop-up. You might want to close out the pop-up. Shows a business model for Singularity.
Is this a bit better? You should be able to see.
There you go.
Okay, perfect. Okay, so yeah, so as you can see here, what BrainWrap basically does is it allows you to be able to have your quote unquote mind read. We're simplifying a lot of the machine learning algorithms behind this there by speaking. So our transcription engine is about 90% accurate. And so, you know, what I wanted to do very quickly is show you what that looks like when you actually rap with it, right? So I'm gonna put on a beat very quickly and we'll talk about some of these things from a rap perspective. So one of the things that I kind of think is clear within healthcare is cost, right? So let's talk about that for a second. The cost of how we change is another place. Our souls are taken apart, and the cost of changes, that's another race. A race that's in their ideas. The idea of race, change for a second, first place. That's what they look for. From MLK to the first place, we look forward to see what can and cannot change in moments that were lost, to the carrot gold. That's the change that we look for. Everything that we've experienced contributes to our greatness as people of color. And that in itself is the roof, the color that changes the discoloration of hate. Changed in places which they wouldn't really know, as we replace every single part of our flow with the minds that we can change in 1 second. The idea of IQ, I really do beckon for a day when things will change in every single way, when dollars and credit can be laid down today, all for the benefit of an entire people. We will change the system so quickly, then we take back what we're making and breaking the flow, shaking the trees down, making it work, holding the knees down, the knees of suffering that were lost to our people in the early part of America, changing for our people. You see, at MIT, we changed the vibe, we changed the healthcare, that's the double diatribe, that's the double meaning, that's never lost to the minds of those who are seeing and feeling the grind. So that's what it looks like when you use this tool that way. You know, the idea behind this is people enjoying rap seamlessly contributes to understanding neurodegenerative diseases seamlessly as well. So yeah, I believe that we've got like 3-4 minutes left. So yeah. Is that time? Do we have
Yes,
Angel?
so yes, thank you, Micah. That was beautiful. We appreciate the presentation. Thank you for the edutainment. We are now going to transition to Sai. I'm not even sorry. I'm not even going to attempt to sign on your last name. With Vanderbilt University School of Medicine. I should know how to pronounce your last name by now, though, Sai. My bad. And so I'm going to learn it. That's going to be my mission today. And
That's
so,
fine.
yes, we're going to turn it over to Sai that is going to go over Hack 101, get your juices going, and show you everything there is to know about what you guys need to do to get through this competition for the weekend.
Thank you, Angel, and thank you, Emery, for the introduction. If you would go to the next slide, please. All right, so I'll try to briefly explain what we're trying to do here. We are trying to democratize innovation. So what that means is bring the power of diversity, design methodology, viability, and community together to solve really hard problems like structural racism in healthcare that we are all here for today. Next slide, please. So the verb hacking has many different meanings. The one most of us are familiar with is the one to gain unauthorized access or to break stuff, but there is another meaning, and that is a creative application of ingenuity. And this is where hacking originally started, and then it got morphed into the other statement above. So we are here for a creative application of ingenuity, using all of our experiences and backgrounds and stories. We bring all of this together to make solutions that will create a big difference. Next slide. So what's different about this hackathon compared to all the others that you may have heard of or have participated in? Well, for one, you have no need to code anything. Well, if you're a programmer and you know software really well, obviously we're not going to stop you from coding, but you don't really need to know how to program any software or even be technologically inclined. What we do need is your ideas and your willingness to create change and bring your background, whatever that may be, in to help make the solution, whatever that is, better. And that comes to interdisciplinary nature of the hack. So we are all different people, like we heard today, and we all have different perspectives on the same issue. And when we put all of our minds together, we come up with the best solution. Instead of just having people who think just like ourselves sit together in a room and brainstorm, that solution is never the best or never works in the real field. So we want people with different backgrounds, different experiences, and different education and skills. So we are going to work on a problem-centered framework. So first thing is to understand the problem, and what that means is try to see the world in the shoes of someone who's actually facing that problem in their daily life, and then imagine what would really help them. So understanding what the problem is where we need to spend a lot of time on. And then finally, we will think about feasibility and business viability, because obviously any solution we come up with needs to be feasible and implementable. So that is also important to take note of. Next slide, please. So what does an MIT hackathon look like? Next slide. Well, in the past, before COVID-19, people will sit in a room, have whiteboards in front of them, and then have a big party and try to hack on different solutions. Well, now we are in a different time and a different world, and so now it looks different. We are all in front of Zoom, and we're working together virtually from across the world and across the globe. So you can do this right from your living room and collaborate with someone on the other side of the world to come up with the best solutions. Next slide. So the process over the next 2 days is going to unfold in this form. On Friday, you're going to do the problem pitch, and then you're all going to mix together, think about those problems that were pitched, choose the ones you liked, and then form teams amongst yourself in your own track. And then on Saturday, hopefully overnight, and on Saturday, your team works on those problems. And once they really understand what the problem is, thinks of different possible solutions, and then comes up with a pitch for the best solution that you can come up with. And we will give you opportunities to pitch your idea, your solutions on Saturday, so we can give you feedback and get you ready for the Sunday. And hopefully on Saturday, you keep iterating on both the solution as well as the pitch, and then you will have your final presentation on Sunday. Next slide, please. And next slide. Yeah, so these were all the different steps that I talked about: pitch, mix, hack, feedback, iterate, and present your solutions. And next slide. Okay, so what are the do's for this hackathon? First, be very open and be open to ideas and from anyone. Doesn't matter what age they are, it doesn't matter what they look like, it doesn't matter what their educational background is. Nothing matters. You have to be open to crazy ideas, and that's what is inspirational about such a hackathon. Leave your job titles at the door. All of us have important experiences and different outlooks on everything that happens around us. So be open to listening to different perspectives and different ideas. And so just leave your own qualifications and degrees at the door. Try to seek diverse teams. And this is very important, as I mentioned, because we only live our life. We don't know how others live their lives. So it's very important to have diverse teams, because diverse teams are the ones that create impactful solutions. And always reach out for help. We have a lot of mentors who are volunteering their time and energy. So please reach out to help in any domain that you need, and we'll try to provide that help for you. And importantly, fail fast and often. Don't get stuck on one idea and try to push it through till the end because you've invested so much in it. The goal is to create the best solution, not something that fancies you per se. So try something. If it doesn't work, move on to the next one. Be open to change. Be open to ideas from others. And then again, focus on the problem as much as you can today, and maybe even most of tomorrow, try to focus and drill down on the problem and understand what the real problem is. And then finally, build something. We will give you the opportunities to do this after Sunday. We don't expect you to have working prototypes by Sunday by any means. So we will give you the opportunity to do that. Next slide, please. Again, don't worry about patenting anything at this point. This is open innovation. Discuss ownership. Don't worry about that either. Again, it's open innovation, so everyone's ideas come together here. Don't come up with a solution that's too broad. The most important thing that you can do right now, during this weekend is to narrow down and drill down to the crux of what you're trying to solve and only provide a solution to that very narrow focus. Don't try to cover everything and anything under the sun with your solution. Don't be negative. Don't be shy. This is the time to have all your creative juices flowing and then express that. Don't try to monopolize the conversation within your team. Again, be open to everyone's perspectives. Try to take action and try things out. Talk is cheap, as they always say, but when we try things out, that's when we know whether something will work or not. Next slide. A good hack always starts with a good story, starts with a real need and meets a real need, can be iterated, tested, and scaled. So always remember this when you go through your solution process. Next slide. I already talked about this, so we'll just skip this one. Next slide, please. Okay, so here's something that is attributed to Albert Einstein. If I only had 1 hour to save the world, I would spend 55 minutes defining the problem and 5 minutes finding the solution. And this illustrates the need to understand the problem first. Next slide. So what are well-defined problems? So you're going right into the problem pitching session after this. The well-defined problem is clear, concise, and it describes the symptoms, the pain points, the problem to be addressed in quantifiable terms. So it enables people to really grasp your question quickly and then come together to solve that problem as the next step. Next slide. So how do you define the problem? Define the who, what, when, where, and why. And so who does it affect? What is the actual problem? When does it occur? Where does it occur? And why is it important to fix it? Next slide. And always remember who the stakeholders, like who are you creating the solution for? So in this case, if for healthcare, it's going to be patients, providers, payers, which is like insurance companies or whoever's paying for it, pharmaceutical companies or industry who are supporting the healthcare system, and then the patient's family members or circle of trust or friends or whoever their loved ones are. Last few more thoughts, be quantitative. Pick a specific customer or end user. Don't try to, again, cover everybody under the sun. Build a persona. And what that means is try to see if you can think of a person and then represent your solution as a part of the life of that person. What are the pain points that they are going through and how will the solution benefit them? Don't confuse your end user and your economic buyer. So the end user is the one who will use your product, not necessarily pay for it. So think about who's going to use it and who might want to be, who will pay for it if that is an important aspect of your solution. Next slide. I already talked about this, so next slide. Okay, so what's going to happen next? We are going to do the problem pitching sessions, and there's also already information on your tracks for that. You will join the Zoom session right after this. And then after the problem pitching session, you will do team registration after talking with other participants, form teams around an unmet need, and then we will send you a team registration link. Your teams cannot have more than 5 people and cannot be a single person as a team. Next slide. So there's different judging criteria, including impact, innovation, implementation, presentation. So in terms of impact, how does the solution solve an ongoing or anticipated problem? Is there potential for widespread impact? Does it address an important challenge identified in the prompt? So the prompt are the track prompts that you are going to be working under. And innovation and implementation are easy to understand. And then in terms of presentation, this is your Sunday pitch. So how effective was it? And then does the team that you form have diverse backgrounds that lends credibility to the solutions that you propose? Next slide. So all of these timelines are posted in the participants guide. So tonight we are doing the introductory session, and we will do the problem pitching session at 9:30, and then team formation after that. Next slide. So if you have any questions through the weekend, make sure to refer to the participants guide. And next slide, please. So that'll be all from me, and I'd like Angel and Yusuf to present some closing thoughts before we go to the problem pitching sessions. Angel or Yusuf?
Yes. Thank you, Sai. That was very enlightening. I hope everybody really took to heart everything that you showcased. It was very sort of clear what we're looking for, and I am excited. So I really look forward to seeing everything, and I'm pleased that we have so many people that are looking to sink their teeth into this subject. I appreciate all of the sponsors, the partners, the organizing team, the judges, the mentors, the speakers, the participants. This has been a true engine. And so thank you all. Yusuf?
Yeah, just to echo what everybody said, looking forward to it. This has been a long dream of mine to actually get the best and brightest, because you know they say if you're the smartest person in the room, you need to get into a different room. So I'm definitely excited about the folks that we've been able to get to participate, be mentors, judges. Let's make this impactful, and let's make the world a better place than we got it.
Absolutely. So when everybody goes to sleep tonight, as Yusuf said, you need to think about how can you fundamentally change the world. Dream as big as possible. Remember, your imagination can take you everywhere. And we look forward to see what you come up with the MIT Hacking Racism Challenge. Special thanks to MIT, and thank you all for joining us, and we'll see you tomorrow.
All right.